talk about anticoagulants and antiplatelets. We're going to start with heparin first. So, of course, we know the basics of giving people heparin is to reduce the risk of developing blood clots. And the thing with heparin is if you've got a blood clot, it's not going to dissolve the blood clot that you have, okay? But it is going to help prevent you from developing new blood clots. And how does it work? Well, this is more of a patho thing, but it produces its major anticoagulant effect by inactivating thrombin and activated factor X, factor XA through an antithrombin AT-dependent mechanism. And it inhibits the reactions that lead to clotting of the blood and the formation of fibrin clots. So essentially, that's what heparin does. When looking at the pharmacodynamics of heparin, it's really a complex thing. So heparin produces its antithrombotic effect by binding to antithrombin 3, and this complex then binds to thrombin. And so in order for them to do this, it takes 18 to 22 monosaccharide units in order for including a specific pentasaccharide binding to that antithrombin 3. So it is a huge process for heparin, this little liquid that we inject into our patients, to actually work. Okay, I made a bit of an error there, so I had to make a duplicate slide. No issues. Oh. All right, let's talk about heparin and precautions and contraindications. Of course, we worry about bleeding, right? That's the main thing that we worry about with heparin is and if you have pain in your chest, groin, or legs, difficulty breathing, you're going to want to stop it. Patients who have platelet counts less than 100,000, unless they're in DIC, really shouldn't be on heparin. You want to avoid the use of anything like aspirin or NSAIDs that can increase bleeding. So there are quite a few non-prescription over-the-counter meds and some prescription meds that contain medications. The most common related problems associated with heparin is thrombocytopenia, bleeding events, and osteopenia. Not a big surprise, right? What are some of the adverse drug reactions to heparin? They can get a rash, itching, swelling of the face, tongue, and throat, trouble breathing, chest pain. So you can have an allergic reaction to heparin. You can also become toxic. So heparin products carry an increased risk of coagulopathy with limb and life-threatening thromboembolic injuries or heparin-induced thrombocytopenia. So we need to consider all of those things. All right, when you're looking at drug interactions, of course, anything that can cause bleeding, NSAIDs, other blood thinners, digoxin, hydroxychloroquine, indomethacin, nicotines, actually, nitroglycerin, and certain antibiotics, cold allergies, sleep medications, all of those things can interfere with heparin. And protamine is a heparin antagonist, actually. So it induces a charge reduction in the glomerular filtrate barrier, so it reduces the efficacy of heparin. All right, what are the clinical indications of using heparin? Well, it's used to prevent or treat certain blood vessel, heart, and lung conditions. It's also used to prevent blood clotting during open heart surgery, bypass surgery, kidney dialysis, and blood transfusions. It's also routinely given to hospitalized patients to help prevent them from developing a blood clot while they're in bed. So there are a lot of reasons it's used. Deep vein thrombosis, pulmonary embolism, AFib. It helps to prevent blood clots by the AFib. thrombosis during cardiopulmonary bypass. So there's a lot of reasons that we use heparin. All right, where heparin's considered, we're going to do laboratory monitoring to measure the anticoagulant effect of unfractionated heparin and adjust the dose to that target range we're looking for. Usually we're going to be doing an activated partial thromboplastin time, or an APTT. Some places call it a PTT. Where I'm from, it was a PTT, not an INR. INR is done with heparin. Two totally different mechanisms of action, which we'll talk about in a minute. Let's talk about dosing, okay? And you can look up a dosing chart online. I would definitely look up a dosing chart, print it out, and put it in with my practicum documents, okay? So it's standard practice to give heparin with an IV bolus of 10,000 units with repeated smaller bolus injections, or weight adjusted. And with the weight adjustment, it's going to be 100 to 175 units per kilogram. Now that's to get it started, followed by 10 to 15 units per kilogram per hour. Okay, then that's someone who's got a heparin drip going, right? So if we're doing injections, or it's different. If we're doing IV heparin, we can see that patient getting a maintenance dose of 40 units a day without incident, okay? But it's going to be different when we're doing injections. So when we're doing the injections, we're going to look at it by weight. And there are different parameters, you know. If you've got, if we're doing DVT prophylaxis, we may do 5,000 units every 12 hours. That's typically what they do in the hospital, okay? So you definitely want to look at the dosages, because they vary, right? If you're doing DVT prophylaxis, we usually do it for at least 10 days to ensure that the patient is up and about. And, you know, of course, there are those individual cases that we're going to do it longer. Okay. All right. So let's talk a little bit about heparin and low molecular weight heparin. And what is the difference? Isn't heparin heparin? No, it's not. There are differences. One of the main differences, you typically will get the low molecular weight heparin is something you inject yourself. It works right away. It wears off quickly. Okay, low molecular weight heparin provides advantages over heparin because it has better bioavailability, longer half-life, simplified dosing, predictable anticoagulant response, lower risk, and lower risk of osteoporosis. And it exerts its anticoagulant activity by activating antithrombin. So it binds both to antithrombin and thrombin when they exceed a molecular weight of 5,000. So fragments of smaller size cannot bind to both antithrombin and thrombin. So if that makes any sense to you all. And we're seeing more and more that low molecular weight heparins are replacing unfractionated heparins because of the advantages of them. Less risk of bleeding, and decreased frequency of dosing. And these drugs are used in the prophylaxis of venous thromboembolic disease, acute elective admission to hospital, all of those things. Lovenox is an example of a low molecular weight heparin. Eliquis, Pradaxa, Xarelto, those are all low molecular weight heparins. You've seen a lot of them in commercials That is for sure. And they like it because there's less risk of bleeding. You don't have to go in and have your INR done, every 3 days, which is a pain in the behind. Um, Now, with low molecular weight heparins, we still have side effects and risks like uncontrolled bleeding, injection site reaction, loss of bone strength, but not as great as regular heparin, elevated liver enzymes, and heparin-induced thrombocytopenia. And most of the like the drug interactions, clinical use, all of those things are similar. Now let's look at warfarin or Coumadin. What's the mechanism of action or the pharmacodynamics of this? It competitively inhibits the vitamin K epoxide reductase complex 1, an essential enzyme for activating the vitamin K available in the body. Through this mechanism, warfarin can deplete functional vitamin K reserves and reduce the synthesis of acting clotting factors. And then we have to worry about a patient's INR. An INR measures the time that it takes for your blood to clot. And this increases when you take warfarin. So we have to watch the INR closely in patients who are taking warfarin. The higher the INR, the longer it takes for your blood to clot. So it helps in preventing blood clots, but it also puts you at greater risks of bleeding. All right, so an INR of higher than 9 is associated with a high risk of bleeding, but most studies look at lower levels. So we look at an INR result higher than 3 may put you at even higher risk for bleeding. And in some instances, 2 may put you at a higher risk of bleeding. Okay, sorry, another slide. I'm running out of time on the slides. So, what is a therapeutic range for an INR? Well, we consider uh, in the United States a therapeutic INR to range between 2 and 3. If you have an INR level above 4.9, that's considered critical and we risk increased bleeding. So we definitely need to address that. I have a really good legal case related to a nurse practitioner and not recognizing elevated INR in a nursing home patient, and it had a terrible outcome. Okay. All right, let's see. Precautions and contraindications. Contraindications include ulcerization or overt bleeding of the GI tract, central nervous system hemorrhage, cerebral aneurysms, dissecting aorta, pericarditis, pericardial effusions, and bacterial endocarditis. Precautions for those taking Coumadin, of course, avoid using sharp objects, use a safety razor, fingernail clippers, avoid contact sports or anything that can cause bruising. In You also have to make some big changes to your diet. Avoid green tea, cranberry juice, grapefruit juice, alcohol, anything that is high in vitamin K. I think that's green leafy vegetables, if I'm not mistaken. Vitamin E can interact with warfarin. Um, So you want to avoid the use of vitamin E, alfalfa, St. John's wort. That's why I always advise students, when you're getting a history from your patient, you want to know if they're taking any over the counter medications or any herbals or homeopathic medications, because those things can definitely interact with medication. Now, of course, you all know that warfarin is not a first line drug of choice, right? Heparin is always going to be the first line drug of choice. Um, most of the time, I'd say 90% of the time, right? Um, now this was 15 years ago, or 14 years ago. I had my hip replaced. The doctor started me on warfarin prior to surgery, and I was on it after surgery. I had to have my INR checked every 3 days. It was a pain in the butt. So I certainly hope that they have changed that practice in 15 years, and I bet you that they did. So let's go on to the next slide. All right, onward to vitamin B12. Vitamin B12 is really an important vitamin that I don't think we spend enough time on. Um, it's the way vitamin D used to be, and we found out that like 90% of people have a vitamin D deficiency. We need to check the B12 too. I just recently had my B12 checked, and my doctor said I was on the low end of normal and started me on B12 sublinguals. So, and there's a lot we need to talk about as far as vitamin B12 is concerned. The tissue absorbs vitamin B12 by specific B12 binding proteins, transcobalamin, and facilitating transport into cells. Most of this vitamin is stored in the liver, and it is essential for DNA synthesis and energy production, essentially in erythroid progenitor cells. Ooh, that sounds really interesting to me. The 5 major functions of B12: normal functioning of the brain and nervous system, cognitive functioning, formation of red blood cells, and anemia prevention. Ding, 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 ding. Helps create and regulate DNA, and it possibly can prevent congenital abnormalities. So we definitely want to make sure that our patient who is considering pregnancy has a really good B12 level. What can block B12 absorption? Some stomach conditions can prevent it, like a gastrectomy, anything where your stomach is removed. People who have the following should not take B12: certain eye disorders, blood disorders, polycythemia vera, gout, iron or folic deficiency anemia, low potassium blood levels, or hypokalemia. You want to avoid those things. It's the more coffee you drink, the more likely you are to be B12 deficient. It's good to take vitamin B12 and vitamin D at the same time. It actually helps in the absorption of it. I always buy liquid vitamins. More of it is absorbed. Okay, let's see what else have we got here. I think we talked a lot about B12. Um, all right, So interactions of vitamin B12 can be vitamin C, proton pump inhibitors, metformin, colchicine, uh, aminosalicylic acid. This is a drug that treats digestive problems. I've never heard of it before. So it must not be something used very often or not used often in this country. We use vitamin B12 supplementation a lot to treat pernicious anemia, or if someone has had an ileal resection, in the treatment of spinal cord myelopathy and many other conditions. We use it in B12 deficiency, of course, cyanide poisoning, and high levels of homocysteine in the blood. The normal dosage of B12 for adults, let's see. I'm looking for it now. And B12 is a water-soluble vitamin. The ideal B12 based on sex and age and the reasons that you're taking it. I'm not finding it. Okay, here we go. I got it. The recommended daily intake for people over 14 is 2.4 micrograms, but it could be more or less dependent on them. Your body can absorb from supplements not a lot, so it's estimated that your body only absorbs 10 micrograms of a 500 microgram B12 supplement. That's why I use a sublingual, because it's going directly into my bloodstream. I'm not losing any of it in my stomach acid. Let's see, if someone is vitamin B12 deficient, it's been found that 500 micrograms a day for 8 weeks will normalize the B12. And you can look for charts on that. If you were going to recommend B12 to one of your patients, you would need to have a good understanding of what the dosage is. And there's a lot of information out there. I'm looking at my my other computer over here. The recommended daily intake for most adults is 2.4 micrograms per day. Okay, 2.4 micrograms, and I would always recommend using a sublingual or a liquid, something that's going to be absorbed before it gets to your stomach, and your stomach acid is going to deplete everything that you just took. Okay? All right, onward. All right, here we go. It was interesting when I pulled this up. I said, oh, only 4 slides. This should go fast. But each slide essentially is like 4 slides. So this one is going to be probably 4 slides if I make errors when I pause. So we're talking about treating inflammatory processes, and this is really something you're going to deal with a lot in family practice. Now, the first thing we're going to talk about is colchicine. Colchicine is an anti-inflammatory. You're mainly going to use it in gout outbreaks. It helps break down the crystals that develop in an acute attack of gout. It also is used in pericarditis. All right? But let's start by talking about the mechanism of action. It prevents microtubule assembly and disrupts inflammation activation. So it disrupts that. It inhibits activation of P2X2 and P2X7 receptors and blocks catatonic dye uptake. All right. So that's how it works. Let's look at precautions. Oh no, I just made a mistake. Hold on a minute. Okay, here we go. Precautions and contraindications. With food interactions, you have to avoid grapefruit juice at all costs. So you don't want to be taking grapefruit juice when you're on colchicine. I think that's really the only contraindication food-wise. If you have severe renal impairment, your creatinine clearance is less than 10, hepatic impairment, or concomitant renal and hepatic disease, you want to avoid it. If I have a patient who comes in with a gout attack, which is the only reason I've ever used colchicine in my career, um, I always have to try to find out what their kidney function is. If their kidney function is out of whack, I'm going to use prednisone instead of colchicine because that doesn't bother the kidneys. All right. So colchicine, this is interesting, may interfere with vitamin B12 in the body. And let's see, there aren't any drug interactions that I can find here. And as I said, the clinical use, you're going to use this in patients who have gout, or if you're working in the ED, acute pericarditis. So let's go on to the next one. Glucocorticoids, prednisone, my favorite. I love this drug. Okay, next up is glucocorticoids, prednisone. I say it's one of my favorite drugs. It does not come without its rotten side effects, but prednisone has saved my life twice. So it is one of my favorite drugs. And how does it work? It decreases inflammation via suppression of the migration of polymorphonuclear leukocytes and reversing increased capillary permeability. It also suppresses the immune system by reducing the activity and the volume of the immune system. For me, prednisone has those horrible side effects. You don't sleep. You want to eat. Um, you might get a little cranky. Okay. But for me, when I'm on it, I feel my best because it suppresses my immune system, makes me feel better. It works by decreasing inflammation. It slows down an overactive immune system, um, and replaces cortisol normally made in the body. And cortisol is that important hormone that responds to stress, illness, and injury. Okay. All right, let me see what else we want to talk about. Uh, so, prednisone has so many functions. Whenever you think of inflammation, you're going to think of prednisone. Okay, so, but as I said, prednisone is not without its side effects. It increases your risk of diabetes. So if you have a patient that's on prednisone, you need to check their blood sugar. Sometimes we even have to put patients on insulin for a while. Gratefully, once the steroids are completed, the diabetes reverses itself in most cases, and then you're good. All right. When you're on prednisone, you want to avoid simple carbohydrates and concentrated sweets like cakes and things like that because of the concern of the development of diabetes, right? So you also need to consider that corticosteroids increase the urinary loss of potassium. So we're going to be wanting to watch those levels. It reduces the absorption of calcium. Big deal. Increasing the risk of bone loss. So people who have been on prednisone for extended periods of time have the risk of developing issues with bone loss. One of them is AV necrosis. AV necrosis is in the large joints of the body. And in AV necrosis is essentially what it means. There is necrosis of the vasculature, so it's not getting appropriate blood flow. And the only treatment is replacement of that joint. All right, so let's see, what else do we want to talk about? We want to talk about, oh, we talked about the side effects already. And I prescribe a lot. Now, with a patient who has no history of asthma, they come in, they've got bronchitis, they're wheezing, I'm going to prescribe something called a Medrol dose pack. A Medrol dose pack comes in a little square container, and it is 6 days of treatment. Day 1 has 6 pills in it. Each pill is 4 milligrams. Day 2 has 5 pills. Each pill is 4 milligrams, and so on and so forth till it gets to day 6, which is 1 pill. Okay, very low dose. It works very well in patients who have no history. Okay. I have a patient who comes in, she's having an acute exacerbation of her asthma, or she's having bronchitis, and she has a history of asthma. I'm going to up it. I'm not using a Medrol dose pack. It's going to be useless for her. It's just not enough. So I'm going to give them 40 milligrams of prednisone once a day for 5 days. Okay, that'll do it. I have a severe asthmatic come in. I'm going to put them on 60 milligrams of prednisone once a day for 5 days. And that's the highest I will go. I won't go any higher. Last time I was in the hospital, I was on 80 milligrams a day. So, but I'm personally not going over 60, and I don't use that very often. I can't remember the last time I used one that was that long ago. Okay? But just remember with prednisone, it's not without its risk. Use it judiciously. Monitor for diabetes. Advise your patients of the side effects that they may experience. We're going to keep a close eye on these patients, but their course of treatment is usually short. The last time I was on prednisone, I was on it for 5 weeks. That's not typical, okay? Your typical asthmatic who comes in with a bronchitis that's caused an exacerbation is going to be 5 days of treatment. Okay, typically that's it. And in 5 days, it's just not long enough for them to have any really horrible side effects from medicine. But they might get a few. They might get, increased appetite, not sleeping, probably not sleeping. Okay? So the next thing we're going to discuss is, all right, let's talk a little bit about acetaminophen, brand name Tylenol. Now, one thing I want to get clear before we start is that Tylenol is not an anti-inflammatory. And some of the research shows that it does have some anti-inflammatory actions, but it is not considered an anti-inflammatory by any means. It works on pain by changing the patient's perception of pain. So it interferes with the conduction of pain. Okay? So it has been thought that acetaminophen induces analgesia by blocking prostaglandin synthesis from arachidonic acid by inhibiting enzymes, COX-1 and COX-2. But it is not a COX-1 or COX-2 inhibitor. So I wanted to get that straight. So it blocks pain by inhibiting the synthesis of that prostaglandin. And prostaglandins initiate inflammation, and it can reduce fever by acting on the hypothalamus. So it reduces fever by directly affecting the brain. That's how it reduces that fever. But remember, it's not a COX-2 inhibitor. It's not an anti-inflammatory, but it does have some characteristics of it, but it isn't. We worry about liver toxicity with acetaminophen, so we want to ensure the patient's not using an excessive dosage because it can lead to liver damage. And Tylenol can interact with warfarin, some seizure medications, and isoniazid. I said that wrong, but that is a drug for TB. You also don't want to drink large amounts of alcohol when taking acetaminophen. Now, Tylenol is considered an antipyretic and an analgesic. All right? So it decreases fever and reduces pain, but it lacks the anti-inflammatory and anticoagulopathy properties. All right. You should not take more than 6 Tylenol in a 24-hour period. So that means that the maximum daily dose of Tylenol for a healthy adult that weighs 150 pounds is 4,000 milligrams. You don't want to go over that. You go over that, and you're going to begin risking liver issues, and we don't want that to happen, right? All right, let's talk about NSAIDs. All right, in talking about ibuprofen, the first thing that we see is that it is a non-selective reversible inhibition of the cyclooxygenase enzymes COX-1 and COX-2. So right there, it's a COX-1 and COX-2 inhibitor, where Tylenol is not. As a result of its action on the hypothalamus, it subsequently leads to vasodilation of increased peripheral blood flow and subsequent heat dissipation. So that's how it reduces fever. Okay, it doesn't reduce fever by directly affecting the brainstem. It is reducing fever by causing vasodilation and increased peripheral blood flow to dissipate that heat, right? All right, where are we going? Side effects of ibuprofen can be headache, dizziness, drowsiness, thirst, tingling, ringing in the ears, blurred vision, fluid retention, ankle swelling. It can also be very hard on your stomach, right? So that's one of the reasons people may take Tylenol if they have a bad stomach. They have a history of stomach acid. They have history of ulcerative colitis. They may take Tylenol because ibuprofen may be something that they cannot tolerate. All right. So you want to instruct your patients to stop taking ibuprofen if you notice any stomach or abdominal pain, black tarry stools, vomit that looks like coffee, shortness of breath, unusual sweating, all of those things that may indicate some type of bleeding. All right. The patient should take no more than 400 to 600 milligrams of ibuprofen 3 times a day with food. Otherwise, it can be bad on your stomach. But we know that prescriptive dosage are much more. Prescriptive doses are going to be 800 milligrams of ibuprofen every 6 hours. But that's not something that should be taken on a daily or regular basis. All right. Medications like ibuprofen and other NSAIDs all of them could be rough on your stomach. And there are a lot of different prescription strength NSAIDs like Toradol, Voltaren, Mobic, Indocin. Those are all super strong non-steroidal anti-inflammatories, and they are prescriptions. Now, last but not least, let's look at aspirin. So when you look at aspirin and the pharmacodynamics of aspirin, it's interesting. It inhibits the activity of the enzyme called cyclooxygenase, COX, which leads to the formation of prostaglandins that causes inflammation. So essentially, it is also a COX-1 and a COX-2 inhibitor, but not at a huge level, right? We use aspirin as a blood thinner. I take an 81 milligram a day. It's effective in the prevention of cardiovascular events in high-risk patients. It impairs platelet aggregation via the inhibition of platelet thromboxane A2 synthesis. Now, 81 milligram a day aspirin is now no longer automatically recommended to be given to all patients, only those that are at high risk of a cardiac event. Okay. Now, if a patient is having a heart attack, you definitely want to give them a couple of aspirin, right? Because that's gonna really definitely help them. All right. With aspirin, we want to be cautious because it can cause headache, upset stomach, acid or sour stomach, difficulty breathing. And the most common side effect is indigestion and stomach aches. So you want to be very careful with that. If the patient develops abdominal pain, change in consciousness, chest pain, constipation, decreased amount of urine, um, you want to be cautious. High aspirin levels can cause liver injury, so you don't necessarily want them to be on high levels of aspirin. We also don't want to give children with febrile illness aspirin. It can lead to Reye syndrome, so keep aspirin away from kids. Some medical conditions like pregnancy, uncontrolled high blood pressure, bleeding disorders, asthma, peptic ulcers, liver and kidney disease might be a bad choice for aspirin. It's not a rule out, but it might not be a good one. There are no foods that you need to eliminate. Let's see, contraindications. If you're allergic to ibuprofen, you shouldn't take aspirin because there's a cross reactivity. That's good to know. You want to avoid the use of NSAIDs. Consider steroid medications, anticoagulants like warfarin and heparin, SSRI, depressants. I hadn't heard that one before. All right, and I think we've covered what I wanted to cover for that. So again, if you have any questions or you have any comments, please let me know. Otherwise, I hope you find this helpful.